since the first report of Kawasaki disease by Dr. Kawasaki himself in 1967, there have been several controversies around this disease. It's a mysterious disease. And today, in the next 1 hour, we'll try to look at these controversies and try to solve some of them. So I'll begin my grand round with this slide that I don't have any conflict of interest and disclosures. So my case is a 2-year-old boy who was admitted to us way back in 2017, about 14 years ago. And he at that time presented with fever for 9 days, pain abdomen 2 days, vomiting for 2 days, loose stools and rash for 2 days. And he was prescribed broad spectrum antimicrobials for last 2 days before he presented to us. And on examination, he was irritable. He had conjunctival injection, which was sparing the perilimbal area, and there was no discharge from the eyes. He also had characteristic strawberry tongue and left cervical lymphadenopathy. The rest of the examination was unremarkable at that stage. So with these clinical database, a clinical possibility of Kawasaki disease was rightly considered at that point of time. And he was investigated on that lines. So you can see he had anemia, neutrophilic leukocytosis. He also had very, very high platelet count. So he had thrombocytosis. His ESR was high and his CRP was also elevated. So in other investigations, he had hypoalbuminemia at that stage. Ultrasonography of the abdomen was carried out and it showed a distended gallbladder. Rest of the investigations were unremarkable at that stage. So with Kawasaki disease as a possibility in mind, he underwent 2D echocardiography to look for coronary arteries. And you can see the first echocardiography carried out on day 2 of the hospitalization showed mild dilatation in the left anterior descending artery and the left circumflex coronary artery. But the echocardiography carried out a couple of weeks later showed giant coronary artery aneurysms in the left anterior descending artery, right coronary artery, and a moderate aneurysm in the left main coronary artery. So he actually received treatment soon after hospitalization with the possibility of KD and coronary artery aneurysms. He received intravenous immunoglobulin 2 gram per kg over 24 hours, which is the standard form of treatment for all patients with KD. He showed some response. However, he continued to have fever and his irritability persisted. And as a result, he received 1 more dose of intravenous immunoglobulin at 1 gram per kg. With this therapy, he improved, his fever subsided, and he was initiated on oral aspirin. However, as we saw in the echocardiography reports, he continued to have the increase in the size of the coronary artery Z scores and developed giant coronary artery aneurysm. So he was rehospitalized, given 1 dose of intravenous infliximab, and also initiated on warfarin and clopidogrel for the anticoagulation, and he was continued on aspirin. So these are his serial coronary artery diameters on echocardiography. So you can see the first 2 that I showed initially. So he came, he had dilatation in left anterior descending and left circumflex coronary artery. However, over a period of just next 2 weeks, he developed giant coronary artery aneurysms in at least 2 arteries and a moderate aneurysm in the left main coronary arteries. So these are some of the subsequent echocardiography reports in this child over follow-up, and this is the most recent, which was carried out in 2018. So you can see he continued to have giant coronary aneurysms in the left anterior descending artery. So the giant coronary aneurysms are defined as a coronary artery Z score, which is more than 10 for that body surface area. And soon after that, his coronary diameters started normalizing on echocardiography. So we did his CT angiography 9 years after the initial diagnosis in the year 2016. And now I'll invite my colleague, Professor Manful Singhal, to discuss the CT angiography findings in this child.
Thank you, Ankur. Now coming down to the CT coronary angiography, which was done on a dual energy 128 slice platform. So here what we can see, this is the volume rendered images in 2 different projections. Here we can see this is the right coronary artery, And we can see this is an large saccular aneurysm, and one of the acute marginal branches is coming through this aneurysmal segment. If we see this is the left main artery, and if we see this is the left anterior descending artery, which is aneurysmally dilated. The same we can see this aneurysmally dilated LCX, which is very well seen on the CT coronary angiographic images, which at times is difficult to see on echocardiography. These are the curved reformated images. What is surprising that we can see the aneurysm that you can see on the volume rendered images now shows on these images as peripheral calcifications. So this is a peripherally calcified aneurysm in the left, in the right coronary artery. These are two different projections saying the same. And if we see the measurements are in agreement with echocardiography. This measures around 5.3 mm in diameter for a length of around 8.8 or 9 mm. And this is the axial images, which shows that this aneurysm is calcified for more than 270 degrees. Now, these are the left anterior descending curve reformative images, in which you can see this is a saccular aneurysmally dilated left anterior descending artery. And here we can see this is showing partial mural calcification. And if we see the proximal LED measures 1.7 mm, and in the aneurysmal segment, it measures 3.1 mm in diameter. Now we see the LCX, this is a curved reformative image in which we see the proximal LED just before it divides into the obtuse marginal branch, showing the saccular aneurysmal dilatation, which measured for a length of 1.4 mm for a diameter of 3.1 mm. If we see the calcium score that the calcium that we seen was restricted, notability is restricted only to the abnormal segments and the aneurysmal segment of the right coronary artery and the left anterior descending artery. And if we see the calcium score, it is coming around 500. And if we see and correlate this calcium score to age, this calcium score age is more than 70 years. So it's a severe amount of calcification present in such young age. So we believe this calcium is probably dystrophic rather than atherosclerotic because it is restricted only to the aneurysmal segments and the amount of calcium score is too high. And this was published in one of the Journal of Clinical Rheumatology, and the editor was kind enough to put our images on the front page. So this was the CT coronary angiographic images for this patient that was done around 9 years after its the last echocardiographic examination. Thank you, Ankar. Let's proceed forward now.
So, thank you, sir, for beautifully describing the CT angio findings in this child. And so before we, I think, move on to the discussion about this disease, we can maybe have a small break and take up some question. As far as the clinical follow-up of this child is concerned, so this child is now 16-year-old and is a national level archery player in India and is doing clinically well on oral anticoagulation. So,
okay, so this child had first come to us in 2007, and he had presented with fever, rash, conjunctival injection, strawberry tongue, and a left cervical lymphadenopathy. So, Ankur, fever is so very common in children. With this clinical presentation, would you have a differential diagnosis?
Thank you, sir. So fever is a very common presentation and in children. So for all pediatricians, so fever, whenever they come see a child who is febrile, the first possibility that comes to our mind is an infection. But I would like to send this message to everyone who is viewing this presentation that, you know, whenever a child has fever going on for a few days and there is no explanation, and especially with the presence of these principal clinical manifestations, so there should not be any other differential diagnosis other than KD. So this patient had all clinical manifestations that suggested a possibility of Kawasaki disease.
So with these cardinal manifestations, in fact, there is virtually no differential diagnosis. So if you see these clinical features in a young child, one has to be sure that you're dealing with KD and you have to start therapy as soon as possible. Now, therapy was given to this child, yet he developed coronary artery involvement. So, Ankur, do you think that is something odd that has happened?
The coronary artery abnormalities in patients with KD do not often develop in the first week, and they tend to develop after this. And so especially in the second week, third week, or sometime up to fourth or fifth week. So some patients with Kawasaki disease, despite receiving adequate therapy on time, continue to develop coronary artery aneurysms. And as a result, now most clinicians across the world are now feeling the need to intensify treatment in patients, a few patients with KD, wherein the risk of developing coronary artery aneurysm is very high. So this is not unusual. This happens, and that is why there has been some paradigm shift in the management of this entity in last few years.
So the message that we get from this child is that even when the first echocardiography examination is normal, it doesn't mean that all is well. And children who have severe forms of Kawasaki disease can go on to develop coronary artery involvement even when the first echo does not show changes. So this implies that one has to do echocardiography serially in these patients, and the first few changes on echocardiography usually appear after day 7 of fever. So in this child, the changes appeared after day 14 or so, and this also can happen sometimes. So Kawasaki disease is an intriguing disease, and one has to be on the lookout for these changes, else you would end up under-treating these patients. In this child, we did CT coronary angiography almost 9 years after the acute episode, and CT coronary angiography revealed calcification. So Dr. Manful, in your experience, how common is calcification in children with Kawasaki disease, and what are the implications of this calcification?
So CT coronary angiography, is now we can say is a recent addition into the diagnostic armamentarium of Kawasaki disease. And we have seen calcium coming in this abnormal segments as soon as 6 months after the presentation. So we don't know at what time this calcification can come. It can come at any time. And it is the modality that will show the mural abnormalities. Vis-a-vis, if we see the catheter angiography, it will show only the luminal information. So calcification tells us probably that's it's a burnt out disease, and it is probably a dystrophic calcification rather than atherosclerotic calcification. I think I've answered your question, sir.
Why was this not picked up on echocardiography?
Sir, echocardiography, that's the biggest limitation of echocardiography. That is why we strongly advocate the requirement of CT coronary angiography that we are going to discuss probably later in this session. The when and in which clinical situation it needs to be done. In a nutshell, it is the left circumflex, the distal segments, which probably was thought that doesn't involve in Kawasaki disease, probably is a myth. And CTO angiography, we are increasingly finding the abnormalities in the distal segments, as well as the mural and other abnormalities in the proximal segments as well. That is very explicitly demonstrated on CT coronary angiography.
So CT coronary angiography is a complementary imaging modality. And in many children, we need to do this in addition to echocardiography to get a complete idea of the degree of coronary artery involvement in children with Kawasaki disease. Is that correct?
I agree with you, sir. Let me put in a form of a statement, if you permit me, sir. In any case, I am so much, dogmatic about my statement is if any children, irrespective whether the coronary arteries are normal on echocardiography, one must at least do in CT coronary angiography once when the child stabilizes to see the entire course and their branches of coronary arteries. And if they are normal, it is quite revealing. And if they are abnormal still, then we have to, follow up with CT angiography as and when the need arises.
Okay, thank you. So we'll go on with the presentation.
Okay. Thank you, sir. So we've seen, the discussion around the controversies about Kawasaki disease. So let's move on to the discussion and see how we can sort out some of these controversies around this disease. So this is one of the most common childhood vasculitides nowadays, and the data on incidence rate of KD are available from several countries in Asia. For instance, Japan reports the highest incidence of KD, approximately 359 per 100,000 children less than 5, followed by Korea and Taiwan. So these are the 3 countries wherein we have the nationwide data available. However, there are no nationwide incident data on KD from other Asian countries, but we have some city-centric data that have been collected from several countries. So if you look at Kawasaki disease from India, so before 1990, there were just 3 case reports. After 1990 and between 1990 and 2000, KD began being diagnosed at several centers in India, and you can see some of the reports coming from various parts of the country. So we don't have epidemiological data available from all across the country, but we do have epidemiological data available from Chandigarh, that is our center. And in the first epidemiological study between 1994 and 2008, so we calculated the incidence in children below 15, and this was as high as 4.54 per 100,000 in 2007. And then there is one more published literature on epidemiology of KD from Chandigarh, that is between 2009 and 2014. And herein the mean incidence was found to be approximately 5 per 100,000 children less than 5. So we recently analyzed the epidemiological data from 2015 to 2019. So this is unpublished, but the incidence is approximately 10 per 100,000 children below 5. So you can see, as compared to many European countries, the incidence rates in India continue to increase, just like many other Asian countries. But in Europe, for example, it has plateaued, but in India, it continues to rise. Now, if you extrapolate these figures to the entire country, we are likely to have approximately 16,000 patients with Kawasaki disease in India every year. And that is a huge number, but we don't, unfortunately, we have not been able to diagnose these many patients every year. So how common is this disease? So I would say that Kawasaki disease is undoubtedly much more common than all other vasculitides combined. In countries such as Japan, approximately 1% of children would develop KD before they reach age of 10. And now KD is the commonest cause of acquired heart disease in children. So another mystery around this disease is what is the etiology of this disease? And for last 50 years, the clinicians and researchers across the world have tried their best to find out the etiology, but it still remains largely unknown. There are evidences that infection is a trigger. So there are clinical, epidemiological, immunological, pathological, and ultrastructural evidence, but this infectious agent remains unidentified at present. There is evidence for genetic component to susceptibility to develop Kawasaki disease, and the evidence comes from that the KD is more common in a few populations, and even when these populations migrate to another country, the incidence continue to remain high in those populations. So this suggests that there is a genetic component to Kawasaki disease susceptibility. Now, which are those genes? So there are some of the genes, as I mentioned here, and these genes have been studied in association with Kawasaki disease. So single nucleotide polymorphisms in some of these genes may be associated with susceptibility to KD. Now, identification of these genes is not only important in identifying the etiology, there are a lot of treatment implications also. And I'll come to that later in my presentation, that identification of polymorphism in some of these genes have actually altered the management. And now there is a concept of giving targeted therapy to patients who have these genetic polymorphism. So the hypothesis around etiopathogenesis of KD is that it develops in a genetically susceptible host on exposure to an environmental agent, which is most likely an infection. The diagnosis of KD is again an enigma. How does one diagnose Kawasaki disease? So American Heart Association has given these guidelines and have revised these guidelines periodically. So this is the latest, which was given in 2017. So the guideline mentioned that in a child with fever, which is going on for more than 5 days, with at least 4 of the 5 below mentioned principal criteria, you can comfortably diagnose a child to have Kawasaki disease. Now I'll mention one of these criteria, each one of these criteria briefly. So bilateral non-exudative conjunctival injection, this is very important. And so this is non-exudative. This is unlike conjunctivitis wherein you see exudates, and this typically spares the area around the cornea, that is limbus. So you can see in this picture. So this is a non-exudative conjunctival injection of Kawasaki disease. Now rash is a very important feature. It can be as prominent as in this patient and maybe as faint as is seen in this patient. The rash is polymorphous. It's maculopapular, macular, erythematous, but usually, not usually, almost always never vesicular. So this is another very important feature of Kawasaki disease. Erythema of the palms and soles, as is seen in this patient. Edema of the extremities. I would say this is one of the most specific feature of Kawasaki disease, especially in young children, and often noticed by the mother that there is edema over the extremities. Periangular peeling of skin is another important characteristic feature, but is usually seen after week 1. So usually seen in the 2nd or 3rd week of the illness. Now, changes in the lips and oral cavity are another important feature. You can see a typical characteristic strawberry tongue and this vertical lip cracking seen in this child with Kawasaki disease. Now, unilateral cervical lymphadenopathy is another important feature, but is usually not seen in more than 50% of the children. And it's usually unilateral, and lymph node is enlarged more than 1.5 centimeter. Now, having said, these criteria are important for diagnosis, but in a given patient, these features that have been mentioned may evolve. So at one point of time, the child may have rash. This may disappear, and then the child may start developing edema over the hands. So these changes do not appear at one point of time. They usually appear sequentially. And one more important point, that these criteria do not differ much from the initial description of the Kawasaki disease criteria given by Dr. Kawasaki himself in 1967. So for the last 50 years, there has not been a major change in these criteria. Now, there are some of the other important clinical manifestations of KD. These are not included in the principal criteria in the diagnostic guidelines. So erythema and induration at BCG site. So as is seen in these 2 pictures, so these are patients with Kawasaki disease, and there is virtually no differential diagnosis if you see this kind of reactivation or erythema induration at the BCG site in a febrile child. Chromonychia is another important feature, and you can see in these 2 pictures, you can see the orange-brown discoloration at the nail tips, and this is another important feature which is being recognized in last decade or so. Arthritis may sometimes be seen in patients with Kawasaki disease, and it usually causes diagnostic confusion. This may be seen in the acute phase as well as in the convalescence. Now, perianal desquamation is another important feature, and this is usually a feature which is seen in the acute phase even before the development of periangular desquamation. So whenever a febrile child has perianal desquamation, this is one of the most very specific feature of Kawasaki disease. In addition, these patients have sterile pyuria, which is a result of urethritis. It is often confused with urinary tract infection. These patients sometimes may have GI manifestation in the form of diarrhea, vomiting, and hydrops of gallbladder is another important feature on ultrasonography. These patients sometimes present to emergency and intensive care with shock myocarditis and macrophage activation syndrome. So these are some of the important clinical manifestations of Kawasaki disease. Now, lab findings in KD are numerous. So these may be neutrophilic leukocytosis, elevated ESR, C-reactive protein, anemia, thrombocytosis, sterile pyuria, as I mentioned previously, elevated transaminases, CSF pleocytosis, and elevated N-terminal proBNP as a result of myocardial inflammation. But most of these are often non-specific and usually do not lead to a diagnosis in a given case. So I think before we move on to the further discussion, we can maybe have a...
So Ankur, you made a very important statement that the diagnosis of Kawasaki disease remains clinical. And this is even after 50 years of extensive research on this topic. So do we know the sensitivity and specificity of the criteria that we use for Kawasaki disease?
So thank you, sir. So as I mentioned in my in the slide when I was mentioning about the American Heart Association diagnostic guidelines, so the sensitivity and specificity of the combined criteria is actually very good, but the criteria taken individually, the sensitivity and specificity is not very high. But so for example, cervical lymphadenopathy is not usually seen in more than 50% of the children in patients with Kawasaki disease. But there are a few features which are very, very specific, like BCG site reactivation, edema over the hands and feet, perineal desquamation, periangular desquamation. So some of these features are very, very specific for a diagnosis of Kawasaki disease.
So Dr. Deepti, based on your experience, what are the common difficulties that you encounter when you are dealing with a child who has fever, and one of the possibilities is Kawasaki disease?
Thank you, sir, for the question. And so even though the diagnosis of Kawasaki disease is based on the standard diagnostic algorithm, which I must remind you have not been revised from the time that they have been created, I feel over the period of last 15 years, we've recognized a lot of atypical and incomplete forms of Kawasaki disease. Fever, which is an essential criteria, fever for 5 days. Often there has been a defervescence of fever earlier, or occasionally patients have come in whom fever has not been a very prominent sign. So that makes us feel that the first criteria, the essential criteria, may not be met with. The cardinal signs are very specific, but many times you have the incomplete form, and as Ankur has already highlighted, there are many atypical forms which need to be recognized. Hence, I believe that often we make a diagnosis of incomplete KD, and these diagnostic criteria that have been labeled needs expansion to involve more laboratory as well as echocardiography, as well as and later angiography to be included, because fever with coronary artery dilatation without any other telltale cardinal sign would also result in a diagnosis of conclusive Kawasaki disease.
So if you have a child with fever and you don't have a diagnosis, and then suddenly your resident notices that there is BCG site reactivation or there is perianal desquamation, is one justified in saying that in this situation, the only possibility is Kawasaki disease?
Yes, sir. I take these two signs very important signs of Kawasaki disease, and treatment of Kawasaki disease should take precedence over finally confirming or labeling a child to have Kawasaki disease. So treating when we have suspicion of KD is important to in clinical practice, because it prevents serious complications of coronary artery aneurysms.
So the point that has been made is that clinical features like BCG site reactivation, clinical features like perianal desquamation, they are virtually pathognomonic of Kawasaki disease in the setting of fever, yet they have not found a place in the diagnostic criteria. So this is a message that we must remember when we are dealing with children with Kawasaki disease. So we'll go on with the presentation.
Okay, thank you, sir. So we have looked at some of the more controversies about the diagnosis of this entity, and we now discuss some of the special situations that one may encounter in patient with Kawasaki disease, and we've touched upon this during the discussion. So incomplete and atypical forms of KD are often confused. So incomplete and atypical terms are different. And incomplete KD we define when there are less than 4 principal clinical criteria in a patient. And one may feel that incomplete KD, because it is not complete, there are not complete clinical features, it may be a benign entity. But there are literature to suggest that it is by no means a benign entity, and risk of coronary artery aneurysms may be higher in these cases because of delays in the diagnosis. Atypical KD, on the other hand, is defined when there are one or more atypical manifestations of the disease, as for instance, in renal involvement, central nervous system involvement, or myositis. So this again leads to a lot of diagnostic confusions in these patients when these clinical manifestations are present. So how do you actually evaluate a child who has incomplete KD, like 2 or 3 principal criteria are fulfilled? You take help of the laboratory criteria, but so these are the guidelines given by American Heart Association for evaluation of a child with suspected incomplete KD. But I would say that so these criteria are there, but the most important point remains the judgment of the clinician in deciding the diagnosis and the treatment. So these criteria should be taken with a pinch of salt when you're evaluating a child with incomplete Kawasaki disease. So it should be clinical, and one should not delay the establishment of diagnosis and initiation of treatment whenever you are dealing with such a child. Another important special situation is Kawasaki disease in infants, and why it is so special that infants almost always present with atypical and incomplete forms, and they do not usually fulfill all the clinical manifestations, and there are several diagnostic difficulties. Another important point about KD in infants is that the risk of coronary artery abnormalities is very, very high. It's approximately 50%. So it has been suggested that prolonged fever in an infant with non-specific symptoms such as irritability, unexplained shock, cervical lymphadenopathy, unresponsive to antimicrobial therapy, that should be the only criteria taken to diagnose a KD in an infant. And not first presentation of KD wherein fever and lymphadenopathy is the only predominant presentation without any other manifestation is a recently described entity, and these patients do not have any other manifestation other than fever and cervical lymphadenopathy. Another important special situation is Kawasaki disease in adolescents and adults. So it may at times affect adolescents and adults as well. So it's not only a disease of children. So in our experience that we published about 2 years ago, so we had about 5% of all patients who had disease onset after the age of 10. And this has been the experience from other centers also, that approximately 5 to 7% of all patients diagnosed at each center are older than 10 years. What is important in this cohort is that there is a delay in the diagnosis, and most of these patients were diagnosed after the day 10. So the median interval was about 12 days. And you look at the risk of coronary artery abnormalities, it's about 13%. So it's much more common than KDC in the usual age group of 1 to 4. So the risk of coronary artery abnormalities in these patients is rather higher because of delays in the diagnosis. And this is one of our adult patient, a 30-year-old lady who was diagnosed to have Kawasaki disease about 3 years ago. And she presented with all characteristic clinical manifestations of the disease. So the key message that I want to give here is that diagnosis of KD may often be missed or delayed. The consequences of a misdiagnosis of KD can be grave. Pediatricians should have a low threshold for diagnosis of KD in children with fever for more than 5 days. And I cannot overemphasize the fact that the diagnosis of KD is clinical, and one should not chase the laboratory investigations for making the diagnosis of Kawasaki disease. So this is our experience which we presented in the 12th International Kawasaki Disease Symposium in Yokohama, Japan. And we observed that we analyzed a patient with KD and coronary artery aneurysms, and the commonest proximate reason for the development of these coronary artery abnormalities was delays in the diagnosis. So these patients had a mean day of diagnosis of 17.2 days after onset of symptom. So one must try and diagnose these patients as early as possible. So next move on to the other controversial issue in this child, and the key message that I want to give before I discuss imaging in patients with Kawasaki disease. We know that echocardiography is the standard imaging modality for patients with KD during both acute and convalescent phases of KD. However, there are several limitations of echocardiography, and we are going to discuss this in a minute. echocardiography alone is not sufficient for imaging patients with Kawasaki disease, and CT coronary angiography provides a paradigm shift in imaging during both acute and convalescent phases of Kawasaki disease. So what are the different imaging modalities in KD we just mentioned? So 2D echocardiography remains the standard because it's easily available in most centers and easy to perform. However, the other imaging modalities such as CT coronary angiography, magnetic resonance coronary angiography, and catheter angiography, these investigations may not be available at all centers. These need skill, and that is why these have not been the standard imaging modality so far. But we'll discuss the limitation of 2D echocardiography and the strengths of the other imaging modalities. So as we discussed initially also, echocardiography has its own limitations. So difficulty in visualizing left circumflex coronary artery and the distal segments of the coronary arteries, as we also saw in the index case that we presented. So the left circumflex and the distal segments were not visible on the echocardiography, but the abnormalities were clearly demonstrated in the CT coronary angiography. Echo is observer dependent. It may be difficult to interpret echocardiography in older children because of the thick chest wall. So we've seen this difficulty. We observed that in children who have thick chest wall, the older children, it may be difficult to interpret echo. And there is a problem with the Z score calculation. So even a minor change in the height or weight calculation may lead to severe changes in the Z score calculations. So this is to circumvent some of the problems, some of these problems with echo, we devised CT coronary angiography, and we've been doing it for last 8 years. Dr. Manful has devised this low radiation technique to assess coronary angiography, do the coronary angiography. And in this study that we published recently, the major highlight of the study is that echo, which could not pick up distal coronaries, which could not pick up left circumflex coronaries, these were picked up very well on CT coronary angiography. And also the complications like thrombosis, mural calcification, and stenosis were very well highlighted on CT coronary angiography and not on echocardiography. Next, we move on to another controversial issue, that is management. So we know that IVIG is the standard, but IVIG alone is not sufficient for high-risk groups and those who have already developed coronary artery aneurysm. So I'll briefly touch, before we move on to the recent advances, I'll just touch upon briefly about how the management of KD has evolved since the first description of KD in 1967. So steroids used to be the initial treatment of choice. However, in 1970, with the introduction of aspirin, there was a major change in the mortality seen in these patients. So introduction of IVIG in 1980 was a major breakthrough. And in 1980s and 1990s, IVIG emerged as a standard of care, while steroids went into disfavor. However, starting from early 1990s, but more so after 2000, there has been a major paradigm shift, and the alternative forms of therapy are being used increasingly nowadays. So these therapies include infliximab, corticosteroid, cyclosporine, and atorvastatin. Now, I'll not touch upon atorvastatin in detail because this is something which is still under trial, but it is one of the therapy that is being used in all patients who have coronary artery aneurysms. So how do you know that which patient need augmentation or intensification of the therapy? So some of the risk scores have been devised. So these three are the commonly used, especially in the Japanese population, but these three scores cannot be used in any other, have not been validated in any other population. So this is one score which was validated in European population. So this is a CAVA-NET score, and with this score you can to some extent predict that which patient would need intensification of the therapy. So corticosteroids went into disfavor in 1990, but for the last about a decade, corticosteroids have been used as an adjunct treatment in patients who are at risk of IVIG resistant or who are at risk of developing coronary artery abnormalities. So after this trial in 2012 by Dr. Kobayashi, so corticosteroids are one of the commonly used adjunct treatment in addition to IVIG. However, steroids have never been the treatment of choice alone in patients with Kawasaki disease. Infliximab is coming up in a big way, and the initial case reports in 2004, 2005, followed by a trial in 2008, 2014, and then in 2021 has shown that infliximab given in patients who are at risk of IVIG resistance, who develop coronary artery abnormalities, the outcome is much better. So we published our experience in 2016, and this was predominantly used in patients who had resistance to IVIG. And then there have been some cost comparison of infliximab versus second dose of IVIG. So the infliximab given in IVIG resistant KD is actually cheaper than second dose of IVIG. Cyclosporin is recently into picture in management of Kawasaki disease. So Dr. Hamada's group from Japan has carried out this trial in 2019. And how does the role of cyclosporin come into picture? So as I mentioned, there are certain genetic polymorphisms, especially the genetic polymorphism in ITPKC and caspase-3 gene, because this is involved in calcineurin and NF-80 pathway, and cyclosporin A blocks this pathway. So that is how the identification of these polymorphisms brought cyclosporin A as a drug in patients with resistant forms of Kawasaki disease. So I just want to mention a few slides about primary intensification of treatment. So the key message is that treatment needs to be individualized, and a few patients would need primary intensification, such as young infants and those who have already developed coronary artery aneurysm. So this is one published study. The key message from this study is that primary treatment intensification with either corticosteroids or infliximab. So it doesn't matter which drug are you using, but you have to use one of these two drugs in patients wherein the risk of coronary artery abnormalities is high. So this is a protective factor against progression of coronary size on follow-up. So I'll give a brief experience about our primary intensification. So this is one case that we managed in 2020. So this 14-year-old boy came with giant coronary artery aneurysms, was diagnosed at day 28 of the illness. And you can see these coronary artery aneurysms on echocardiography. And we treated this child aggressively with IVIG, infliximab, steroids, cyclosporin, aspirin, LMWH, and atorvastatin. And you can see the regression of coronary aneurysm seen at 2 weeks and at 2 months of follow-up. This is another case that we recently managed, and this boy came from Delhi, and these are the giant coronary artery aneurysms in the initial echo, again managed aggressively, and you can see the regression on CT angiography, and this is just a small segment of LAD, which is aneurysmal now, and rest of the aneurysms have completely normalized. So we analyzed last 3 years of data, about 45 patients with a median age of 3.5 years. There was a delay in initiation of treatment in patients who had moderate and giant coronary artery aneurysms. And you can see what I want to highlight is that approximately 1/3 of these patients were treated aggressively with IVIG, infliximab, cyclosporin, and corticosteroids. And these are the outcomes. So we saw that regression of aneurysm was seen in approximately 42%, while 26% there was reduction, but it's still kept on, the aneurysm was still there. And this was at a median follow-up of approximately 1 year. So this is my last slide, and I wish to acknowledge my colleagues from the allergy immunology unit and the DM fellows in our unit, Dr. Archan, Dr. Supreet, and Dr. Ridhima, who helped me in collecting the data from our unit. Thank you very much.
Okay, thank you, Ankur. So I think before we open the case for discussion, may I request Professor Satish Kumar to share his experience of Kawasaki disease in context of COVID pandemic, and especially the newly described syndrome, MISC. Professor Satish.
Yeah, thank you, Dr. Surjit. Is my slides on the visible and I'm audible?
Yeah. So you're audible, yes, sir.
Yes, thank you very much. Good afternoon, friends. I'm just going to talk our experience about MISC with Kawasaki disease. So next 5 minutes, I'm going to give an overview of case definition in MISC, and what is the MISC KD overlap, and what is our experience in our CMC Vellore. So as you all know that multi-system inflammatory syndrome in children, we have 3 definitions, one from United States CDC, another one from UK, and another one from WHO. All of them said the same thing. Basically, they should have fever during the episode of COVID-19 pandemic, and they should have evidence of COVID-19 infection and clinical features which will involve multi-system. And if you look into the WHO, this is very simple and easy to follow. They said any child who has got fever more than 3 days during the pandemic of COVID-19, if they have two of the following, especially rash, bilateral prone conjunctivitis, on oral hand or feet changes, hypotension and shock, or involves mainly the heart, myocardial dysfunction, pericarditis, valvulitis, or coronary abnormalities, and evidence of coagulopathy or GA symptoms. The two of those things should be there, and raised inflammatory markers and no other obvious cause of the symptoms which are described above, and you should have evidence of COVID-19 infection in the form of RT-PCR or antibody. So this is one of the biggest case reviews of children who are admitted with PIMS, TS or MISC. If you look into this, almost 55% of them have rash, and another 50% have conjunctivitis, and 25% of them had complete KD, and another 25% had incomplete KD. So almost 50% of the children who present with MISC have Kawasaki-like signs. So is it Kawasaki, is a MISC a form of Kawasaki disease? As we are talking now about KD in detail by Dr. Ankur, even till the pathophysiology of Kawasaki disease is unclear. It is a trigger, usually unknown trigger in a genetically predisposed patients where you have very high inflammatory markers produced by overacting Th1, Th17 pathway, leading to pro-inflammatory cytokines, causing all the medium muscle vasculitis in Kawasaki disease. In MISC, what we know so far, the trigger is COVID-19. Usually, after 4 to 6 weeks of COVID-19 pandemic in the adults, children develop this MISC, again in a genetically predisposed children, where here there is excessive pro-inflammatory cytokines leading to cytokine storm, leading to all the clinical manifestation of MISC. So MISC is a KD triggered by SARS-CoV-2 infection or a syndrome characterized by the multi-system inflammation that mimics KD. So when you compare the MISC and KD, this is a typical KD which Dr. Ankur has talked about, the classical KD, less than 5 years, viral trigger. We have the classical 5 features, and they have leukocytosis, thrombocytosis, and it is usually mediated by IL-1 cytokine. So when you come to the MISC, as I told, 4 to 6 weeks post SARS-CoV-2 infection, older children, they have very high elevated cardiac enzymes. They have more of GA involvement, cardiac dysfunction, shock, and lymphopenia. And here, usually we treat with IVIG, they got better. Here, they need inotropes, ventilation, and even ECMO. Most of now, what we found out is this MISC cytokine storm is mediated by IL-6 and IL-10 mediated. So similarities when you look, they have fever, they have rash, conjunctivitis, cardiovascular involvement in the form of either myocarditis or coronary artery aneurysms. They have very high lab inflammatory parameters. They can develop MAS and shock. So when you look into that, as I said, MISC is in older children. Kawasaki disease is less than 5 years old. Again, KD is very common in Asian descent. Here is in Black and Hispanic descent. Gastrointestinal symptoms, which are very common in MISC, KD is only 20%. And myocardial involvement in the form of shock, needing vasoactive support, is very common in MISC. Multi-organ dysfunction is common in MISC. Inflammatory markers are very, very high, and they have lymphopenia and thrombocytopenia. And treatment, most of the time, here we stop with IVIG. Here we have to give glucocorticoids, IL-1 blocker, and IL-6 blockers. So these are the typical rash, what we've seen in some of our patients. You can say typical conjunctivitis. Because a big girl with the MISC, you can see again conjunctivitis. This is a rash, faint maculopapular rash seen on the body. Typical peripheral changes seen in children with Kawasaki disease, the rash, and this is a peripheral edema, which is again seen in children with MISC. So cardiac manifestation, when you looked into the MISC, you can see that in MISC, 14 to 48% of the children can develop coronary artery dilatation. Almost 50 to 80% of them can develop cardiogenic shock also. So what we do when the children present like this is a protocol we made during our first wave. We see a lot of children with MISC. So when you look into that, we divide the MISC is not a single presentation. They have various categories of presentation. Sorry, various categories of presentation. When you look into this Kawasaki, they can present like incomplete Kawasaki, like they only had rash and eye changes, plus or minus shock. We treat them with 2 grams of IVIG and methylprednisolone, 2 milligrams per kilogram. If they have present the complete Kawasaki-like illness without shock, we treat like the typical Kawasaki disease. We give the standard IVIG 2 grams per kg plus aspirin. So these are the big series of PIMS, TS or MISC from India. The first one is from Mumbai. There they, for doing the first wave, 23 patients. Out of that, 26% of them had coronary artery dilatation. This is again from Kanji Kamakoti Trust in Chennai. They also reported 19 patients. Only fewer children in this series have coronary artery abnormalities. We also published our experience during the first wave. We had 17 children who presented with the MISC. If you look into that, rash was seen in almost 10 children. 16 children had hypotensive shock. So this is our second wave. We have 55 children during the second wave. KD phenotype had 15. KD phenotype with shock, 8 children had. And coronary artery involvement is seen in 3 children. During the third wave, from this January, what we saw is we didn't see much patient this time. We saw only 3 children with the MISC. And a lot of children we suspected, but they all improved with antibiotics alone. We didn't treat like steroids and all. So they had 1 had KD phenotype with shock and 2 had coronary artery abnormalities. So take home message, there are similarities between and differences between the epidemiology, manifestations, treatment protocol, and prognosis with the MISC and KD. Genetic susceptibility resulting in KD and MISC remain to be determined. Give standard therapy. So don't worry whether it's MISC induced KD phenotype or Kawasaki disease. Give the standard therapies and follow the protocol. And if you delay the diagnosis or failure, can lead to unfavorable outcomes, especially related to coronary artery aneurysm. I will stop here with my presentation. Remaining, we will have it during the discussion. Thank you very much once again.
Okay, thank you, Dr. Satish. That was very useful. Before I hand over the mic to the 2 moderators, do I have their permission to take up a few questions that have come up in the chat box?
Sure.
Okay. So the first question is, do you see macrophage activation syndrome in Kawasaki disease? And if so, how do you treat? I'll ask Dr. Deepti to take up this question.
Yes, so we often see macrophage activation syndrome in association with Kawasaki disease. And this is one of the indications to use corticosteroids upfront. So myocarditis and macrophage activation syndrome are 2 important criteria. So we use methylprednisolone, 30 milligram per kg, 3 to 5 days. And we also, in addition to IVIG, and add cyclosporin. Most of the patients would be controlled on this. Very rarely, I recall 2 patients in whom we had to use additional therapies like either infliximab or tocilizumab in addition. And there are reports of patients needing the full HLH protocol to control macrophage activation syndromes. That happens probably in a genetically predisposed child who has an add-on KD. But most of the time, it is methylpred and cyclosporin.
In your experience, is it a measure of disease severity? Children who develop macrophage activation syndrome, do they have more severe forms of Kawasaki disease?
Yes, sir. I believe that patients who develop macrophage activation syndrome have more severe KD, though the classic relationship between development of mass and development of coronary artery aneurysms may not be very well established. But definitely they are more sicker. They have more serious disease.
How long do you treat children with Kawasaki disease, and how long do you follow up these children?
So most children would be treated with single dose IVIG, and the aspirin is continued for 6 weeks. We do a follow-up echo at 6 weeks. If the coronaries are normal at 6 weeks, then we stop aspirin therapy. However, if the patients have coronary artery aneurysms or they have a coronary artery disease, aspirin plus minus clopidogrel would go on for a longer period of time. And subsequently, we probably never discharge them from a follow-up. We've recognized that these patients require more stringent care and a longer care for long-term outcomes that need to be seen in these patients. So every child who has KD should be followed up in the clinic. That's what I believe.
Okay, thank you, Dr. Deepti. The next question is, do children with Kawasaki disease go on to develop adult vascular disease?
Sir, this question, to my understanding, has 2 points. One is, can these children tend to have these abnormalities for a long? Quite possible, sir. Another question, another point to my mind is, can these children who probably had Kawasaki disease never went for the appropriate treatment? When we do CT coronary angiograms, we often find that their patient coming with atypical chest pain, and when we do CT coronary angiogram, we find coronary artery aneurysms. And in fact, in one patient, we found a thrombus in one of the large secular aneurysm in the left-handed descending artery. And to be very specific, if I say whether this coronary artery abnormalities of Kawasaki disease can lead to some other kind of vasculitis in adult patients, that question is maybe very difficult to answer at this point of time.
When you are following up children with Kawasaki disease, how soon have you documented calcification of the coronary arteries?
Sir, we have seen one patient developing calcification at 6 months at follow-up.
So calcification can occur as early as a few months after the disease has been diagnosed and treated. Ankur, you have been using cyclosporin lately in children with Kawasaki disease. Do you use oral cyclosporin, intravenous, and what is the duration of therapy?
Okay, so cyclosporin we've been using oral, so we never give IV cyclosporin to these patients. And so if you look at the trial settings, so the cyclosporin has been used for a very short duration, for about 5 days. But there has been a general consensus among experts that it should be used a little longer. So in our experience, we give 4 to 5 mg per kg per day dose, and we give it for approximately 2 to 3 months. So that is the way we treat these patients.
Okay, so we have covered most of the questions in the chat box. So I would now leave the floor for the 2 moderators.
Thank you, Professor Surjit, for conducting this beautiful case presentation and discussion. And we all agree that probably after Japan, in the whole of Asia Pacific region, there's no other better center than Dr. Surjit's center with so much of experience in Kawasaki's disease. Dr. Surjit himself had worked with Kawasaki on several times, and they had exchange visits many times. I have actually lots of questions here, apart from one of the audience and few from some of the faculty questions. If I'm allowed to ask, I know you have overshot the time by a few minutes. One of the questions which comes in our mind is, would you have managed this case differently if this child was admitted with you in the year 2022 rather than in 2007? Dr. Surjit or any of your team members?
Yes, I think that was the main reason why we presented this case. So in 2007, I think we were rather diffident in using modalities other than intravenous immunoglobulin. So it was around this time that Dr. Jane Burns had visited our center, and she prodded us to start using infliximab in children who have more severe disease. But we were still not very confident. So in this child, we saw the coronary artery damage evolving in front of us. So, and we used infliximab maybe after 3 weeks or so. But given this child again, I think he would have received the entire spectrum of drugs. That means intravenous immunoglobulin, methylprednisolone followed by oral prednisolone, infliximab, as well as cyclosporin. And that may have helped in remodeling of the coronaries. But at that time, I think that was the standard of care which was used at most centers.
Thank you, sir. There's a question from Holland, whether is this treatment what you have followed is an agreed upon management in Asia? Dr. George Bruin.
Sir, I mean, the answer to this question is both yes and no. So there has been a general consensus. So it's not into the literature that these patients need to be treated aggressively. Like, how aggressive do you want to be? So that is left to one's discretion. So that is, I would say, our policy that we tend to use aggressively by giving cyclosporine, steroids, infliximab, and IVIG. A few centers maybe use 3 of these 4 drugs. A few centers maybe use 2 of these 4 drugs. But there has been a consensus now that these patients need to be treated aggressively. Yes, sir.
Okay. Thank you. The next question is from Dr. Jasper Borromeo. Can procalcitonin levels be elevated in Kawasaki and MISC in the absence of concomitant bacterial infection? We have seen MISC patients with no clear focus of infection and negative cultures and have elevated procalcitonin. Dr. Satish, maybe?
Yeah. So you know that procalcitonin is a marker for bacterial infection and also it's an inflammatory marker. So what happens in MISC, as I said, that we have a preceding SARS-CoV-2 infection 4 to 6 weeks earlier. So it's like a post-inflammatory response we see. And I told it is mediated by IL-6 and IL-10. That may be the reason, even with the cultures being negative, they have very high CRP, ESR, and procalcitonin compared to the children with Kawasaki disease. Kawasaki disease, again, we said that a lot of times is viral induced and it is not very severe cytokine storm like MISC. So in children with the MISC, that's the reason where your ferritin, D-dimer, procalcitonin, ESR, CRPs are almost in 3 digits compared to the normal or pre-pandemic Kawasaki disease.
Thank you. There are 2 questions on why did you use anticoagulation and clopidogrel in this patient. Dr. Surjit or anybody in the team?
So aspirin is indicated in all patients for the first 6 weeks. And if you demonstrate that there are no coronary artery abnormalities, then we tend to stop. Dual antiplatelets are required in patients who have coronary artery aneurysms, and we follow these patients over a period of time, and these patients tend to require antiplatelet agents for a longer period of time. In patients who have giant coronary artery aneurysms, however, anticoagulation is warranted. And as this child had giant coronary artery aneurysm, and that is the reason why this child was on anticoagulation, because of the fear of thrombosis that can happen much often in patients who have giant coronary artery aneurysms. So even though we did not demonstrate thrombosis, but giant coronary artery aneurysms is an indication to use anticoagulation in these patients. Ankur can add.
So I completely agree with what ma'am said. In fact, I remember asking Dr. Adriana Tremole from US once, like, can you, like, rather than giving low molecular weight heparin in 2 divided doses, you know, after a period of time, can you switch them to once in a day dose? So they were so scared that, you know, they've seen situation wherein it was given once daily and the child came with thrombosis. So coronary artery aneurysms are scary, and we have to give long-term anticoagulation to these patients in treatment doses. So that is my. Yes, sir.
Thank you. The next question is from Dr. Nada Alkama on, can we treat KD by IL-1 inhibitors?
So IL-1 inhibitor, there are, I think, at least 2 trials that are going on, one in US and one in Europe on IL-1 inhibitor anakinra. And I think there is one on probably canakinumab also. that if that can be used as a treatment for Kawasaki disease, because that is a very, very safe treatment. But in our country, that availability is an issue. So we don't have easily, this anakinra is not easily available. So we have not used anakinra in any of our patients with Kawasaki disease. We've used in few other conditions like autoinflammatory syndromes, but not in Kawasaki disease. But yes, this may be one therapy in future for patient with Kawasaki disease.
Thank you. The next question is from Professor Nighat Ahmed from Pakistan. How long would you follow by serial echocardiogram and serial CT angio in a patient of KD?
If the coronaries show normal, if the coronaries are normal at the 6 weeks echocardiography examination, we need not repeat echocardiography. So during the first few days, we would do echocardiography virtually on a daily basis. Then we would do it at the time of discharge, call the baby at around 6 weeks. If that is normal, we would not do further echo examinations. However, if the 6 weeks examination shows dilated coronaries, then we would continue following up these patients till the coronaries have regressed. If there are aneurysms, then we need to do more aggressive forms of imaging, that is CT coronary angiography, and these children would need virtually lifelong follow-up.
Thank you, sir. And next question is interesting. If there's a giant aneurysm at the onset, would you recommend surgical intervention?
Deepti.
So surgical treatment is performed, requires extreme skill and expertise. And this unfortunately is not readily available in our setting as well as in other Southeast Asian setting. There are reports of surgical procedures being performed by, I'm forgetting the doctor's name, sir, who is, and those surgeries, he has done some surgeries on patients with giant coronary artery aneurysms, and I request Professor Singh to talk about his experience.
If you're talking about the acute stage, if you have a giant coronary aneurysm during the acute stage, treatment is only medical. We don't touch such aneurysms. There is no way anything should be done or can be done for these patients. So it has to be medical treatment. As Ankur mentioned, we would augment therapy, give all 4 anti-inflammatory agents, follow up these children. Majority of these children would show regression of the aneurysms. The aneurysm size will decrease. Sometimes it would normalize, but after 10 to 15 years, they would be narrowing at the 2 ends of the aneurysm, and you will get stenosis. So we consider surgery only on follow-up, say when the child is around 15 to 20 years of age, in very selected patients. And that kind of surgical skill, as Dr. Deepti mentioned, is not easily available. So it's a very difficult situation that we are talking about.
Thank you, sir. There's another question. If there is a case with a normal C-reactive protein, would you consider a different diagnosis from Dr. Sarah? Yes.
Yeah. So the CRP, as I said, is IL-6 mediated, is important marker for inflammation. So in a child with MISC, CRP has to be high, especially mostly in 3 digits. So if the CRP is negative, you look for an alternative diagnosis than labeling as MISC. You look into all the other parameters. You do procalcitonin, you do ferritin, all the other markers. So don't go one by only CRP negative. Can I rule out MISC? Rule out all the other infections before you label them as MISC. Don't over-treat MISC because in India, places wherever I practice, infection is still more common, and they always keep the tropical infection in the mind, especially rickettsial infection, dengue, and typhoid. All those things can present with similar presentation like MISC.
Thank you. There are a whole lot of other very good questions, but one question I would like definitely Dr. Sujit to answer is, if you have an adult patient with KD, would your treatment approach or recommendation be different? Because most adult rheumatologists are not that familiar with KD.
I think this is a very important question. There are two situations where KD is likely to lead to several complications. One would be infants below the age of 1. And younger the infant, more likely are the complications. In fact, diagnosing and treating Kawasaki disease in babies below 6 months is a nightmare. The other situation where KD is likely to have several sequelae is in adolescents and adults. So in these situations, one would generally be much more aggressive. That means in addition to intravenous immunoglobulin, you would probably use infliximab preemptively. So the short answer is yes, we would be more aggressive and we would use infliximab in addition to intravenous immunoglobulin if we diagnose Kawasaki disease in an adolescent or an adult.
Thank you, sir. I would like to, if our secretariat can allow Dr. Suma Balan to come live to give a 2 minutes comment on this. Before that, I have one more question by the time she comes live is how long would you wait for IVIG and steroid response before you declare it's a failure and you need to change to infliximab? This is by Dr. Nia Kurniati. I'm sorry if I pronounced your name wrongly.
Generally, when we treat children with Kawasaki disease, we wait for approximately 36 hours. If the fever continues after 36 hours, that is a red flag sign, and we need to augment our therapy. So you give IVIG, wait for around 36 hours. If the fever is still persisting, this is a measure of IVIG resistance, and this is taken very seriously. And you would augment your therapy either with infliximab or with steroids or with cyclosporin, but quite often with all three at the same time.
Thank you, sir. Dr. Suma Balan, welcome. She's a very accomplished pediatric rheumatologist in India. She was trained in the UK. Professor Suma Balan leads a huge clinic. Would you like to share in a minute or two your experience in relation to this case?
First of all, I think it's been an extremely really well brought out clinical case story showcasing the entire spectrum of Kawasaki disease, the challenges involved, and the newer updates in the treatment process. It's very instructive and very, very useful. And I think Satish's follow-up on MISC was another really good overview of the condition. I think it's interesting. A few years back, when we had the Kawasaki conference and we were sharing information from across the different parts of the country, we saw that there were more children presenting with shock syndrome in the western part of India, and more children presenting with large aneurysms in the northern part of India. And so there seems to be some kind of regional difference in the way that the clinical presentations happen as well. Our presence in South India, I think where I live in Kerala, is a place where pediatricians are picking up Kawasaki's extremely well. They are tuned to it, all the teaching and training that has gone into it, they're picking it up really well. So we tend to see more of the complicated cases in my center compared to the straightforward diagnosis of these cases. And increasingly, one of the recent very challenging cases I had was a young infant with Kawasaki disease who had a resistant macrophage activation rather than, and he, at the point he came to us, it was not about his, it was not about the coronaries, they were still. So since we have anakinra stored in our hospital, I elected to use that in this child. This child already was given IVIG, was given steroids. So we added in anakinra, and it made a dramatic change. we just needed to give about 4 days of anakinra, after which we made it a slightly smaller dose. A total of, I think, 7 days in total, like the whole process. And it turned the disease around. The child is doing extremely well on follow-up. So it is, if we can get the drug in India, it has multiple uses, multiple situations where it can be very, very helpful for pediatric rheumatology use. And that is something that would come up. The other important thing is for people, as Ankur has stressed many times, it is to try and identify the possible scenario of steroid IVIG resistance early on in the diagnosis, so that we can stratify the treatment of these patients right in the beginning and reduce the problems later on. Thanks.
Thank you, Dr. Suma, for your comments. Now, we are winding up in next 5 minutes. I have the pleasant duty now to ask Professor Sujit Singh first to give a final take-home lesson from this case, followed by Dr. Priscilla Wong, the chair of the APLAR Young Rheumatologist Forum, to explain about the APLAR Grand Round and other activities which the participants, the audience would like to know. And then we probably have to, like all good things come to an end, this will also come to an end. So first, Dr. Surjit and Dr. Priscilla, and then.
Okay, thank you, sir. Thank you for giving us this opportunity. So the take-home message is rather straightforward. When you are dealing with a child who has fever, unexplained fever, fever has gone on for more than 5-6 days, we must have a low threshold for diagnosis of Kawasaki disease, because unless you diagnose these children really early and unless you treat them appropriately, they are likely to develop coronary artery aneurysms. And these aneurysms, once they develop, they are likely to stay. So the consequences of missed Kawasaki disease are very grave. And this is one disease which doesn't give you a second chance. So if you hit hard, if you hit early, the response to therapy is very gratifying. And this is what the lessons that we have learned over the last few years. Thank you.
Thank you, Professor Surjit and your team, for an excellent presentation. I would now invite Professor Priscilla Wong to have her deliberations.
It is such a precious opportunity. We can have all the top-notch faculties of Kawasaki disease speak to us today on this very mysterious but very important rheumatological condition. I saw there are still a number of questions in the chat box remaining unanswered due to the time constraint. Don't worry, we still have the opportunity to continue our discussion and to share our view. Let me introduce you to our APLAR Grand Round bundle activities. APLAR Grand Round is not only a webinar, but also comprised of APLAR Grand Round Forum and APLAR Blackboard. So what is APLAR Grand Round Forum? It is an online platform on APLAR website that is open to all to give comments, share knowledge, exchange ideas, and your experiences. So all attendants are invited to write in this forum around the theme of the Grand Round. You just need to visit our APLAR website, then go to events, and then click on APLAR Grand Round. So the APLAR Grand Round forum for today's Grand Round is already opened. For APLAR Blackboard, we have this questions posted on our APLAR website. So you can test your understanding of today's Grand Round lecture and test your knowledge about Kawasaki disease. We have already posted 2 challenging questions prepared by our presenters and our guest faculty. They are practical case-based MCQs. So once you choose your answer, then the proper correct answer will pop up with a detailed explanation and some references will be provided. So please join us to visit the APLAR website immediately after the Grand Round, click on events, and then click APLAR Grand Round, APLAR Grand Round Blackboard. And this is our APLAR Grand Round 2022 schedule. This is a year-round activities. It is a bi-monthly educational activities under the umbrella of APLAR Academy. Each time there will be one AYR members and some guest faculty invited to give their experts' opinions, and they're all from the Asian Pacific region. So the next APLAR Grand Round is scheduled on the 25th of June. The theme is lupus, and the country presenting for us is Nepal.
Thank you, Dr. Priscilla, for doing such beautiful conduct of the AYR activities and also facilitating APLAR Academy to carry out its activities. The Grand Round is a new initiative which is solely run by the AYR, and we have been doing it so well. It is educative, not only for the young dermatologists, but for all of us. So thank you for the great work you are doing. I would like to just take 1 minute before I conclude, is to say that those who are not familiar with APLAR Academy, this is the new center of education which is created by APLAR, and this is led by Professor Laishan Tam from Hong Kong, and all APLAR academic activities is under that. And this is APLAR Academy is actually a functioning body of APLAR Education Committee, which is led by Professor Catherine Hill in Australia. I would also like to say that we are having for the first time the midterm symposium of APLAR. This will be held on May 29th, and this will be post-fixed with the Bangladesh Rheumatology Society meeting on 30th of May. We have on 29th of May, 12 special interest groups of APLAR will be presenting on the state-of-the-art presentations or the advancements that has happened over the last 1 year. And please don't miss this. Please encourage your colleagues to present. And finally, before I conclude, I would like to say I'm sorry if I missed out anybody, but I certainly missed out our Japanese friends to comment on Kawasaki's disease, and they are one of the good collaborators, Professor Singh, and of course no one knows probably Kawasaki earlier than them. So I would like them to. You'll hear Professor Tanaka's team doing the lupus webinar and the lupus day. So he's another accomplished clinician scientist. So please take part into all the APLAR academic activities, and thank you very much for patient hearing, and sorry for overshooting the time by half an hour, in fact. But I can still see that more than 175 people are still attending. So thank you, and appreciate your support in taking APLAR educational activities forward. Thank you, everyone. I would like to thank the APLAR Secretariat staff also for conducting it. Professor Singh, Professor and his team, Professor Satish Kumar, Dr. Priscilla, and everyone who is involved in this for the great success of this meeting on Kawasaki's disease is something which we often do not diagnose, and often we miss out, most likely. Thank you. Bye for today. See you soon. Can you stop recording, Stephen?